Hello everyone, and welcome to today's webinar on disruptive behavior disorders in children. My name is Tamara Moore with the Reese Group, a communications firm in DC. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On your screen, you should see a screenshot example of your attendee interspace. You have something like this on your own computer screen in the upper right-hand corner. If you've joined today's webinar by phone, please enter your PIN number, which can be found on the audio pane of your control panel. All attendees will be placed in listen-only mode. You will have an opportunity to ask questions during today's discussion. To ask a question, submit your text question through the Q&A section of your attendee control panel. We will collect all questions and address them during the Q&A session at the end of today's presentation. If you have a question or an issue with the webinar technology, you may type your question through the Q&A section of your attendee control panel, and someone will respond to you as soon as possible. You may also contact GoToWebinar technical support by dialing 888-259-8414. Today's presentation is being recorded and will be posted on the Society of Clinical Child and Adolescent Psychology's website in the coming days. I would now like to turn the call over to today's moderator, Dr. Mitch Prinstein, President of the Society of Clinical Child and Adolescent Psychology and Professor of Psychology and Director of Clinical Psychology at the University of North Carolina at Chapel Hill. Mitch?
Thanks, Tamara. Thank you all for joining us today. The Society of Clinical Child and Adolescent Psychology, or SCCAP, leads the advancement and practice of evidence-based therapies based on psychological science. In recognition of National Children's Mental Health Awareness Week that wraps today, the Society wanted to host an interdisciplinary panel of mental health experts to discuss disruptive behavior disorders, including a presentation of a recently released review of evidence-based psychosocial treatments. Today, we are joined by three experts in children's mental health to help frame our discussion and provide their perspective. Steve Lee, President-elect of SCCAP, is a clinical child psychologist and an associate professor in the Department of Psychology at the University of California, Los Angeles. Jennifer Kaminski is team lead of the Child Development Studies within the Centers for Disease Control and Prevention's National Center on Birth Defects and Developmental Disorders Division of Human Development and Disability. Our final speaker, Jess Shatkin, is a child and adolescent psychiatrist and an American Academy of Child and Adolescent Psychiatry member expert. He leads the educational efforts of the NYU Child Study Center, where he is Vice Chair for Education and Professor of Child and Adolescent Psychiatry and Pediatrics at the NYU School of Medicine. With that, I'd like to turn it over to Steve.
Thank you, Mitch. Good afternoon, everybody. So I'd like to start off today's presentation with a little bit of a review about the defining features of disruptive behavior disorders in youth. So disruptive behavior disorders broadly refer to a set of behaviors spanning physical aggression, significant oppositional behavior and noncompliance, property destruction, as well as various forms of delinquency. Now, when behaviors are present for a significant amount of time, and when those behaviors result in significant impairment, meaning academic problems, social problems, family conflicts, and so forth, these behaviors can result in a diagnosis, a formal diagnosis of, for example, oppositional defiant disorder, or ODD. Similarly, if behaviors are present for a requisite amount of time with a particular onset, lasting for at least 6 to 12 months, for example, consisting of physical aggression, property destruction, or significant delinquency. So, for example, behaviors related to violation of rules or normative expectations, so breaking curfew, truancy, alcohol and substance use, for example, that can result in a diagnosis of conduct disorder. So disruptive behavior disorders overall, or as a class of problem behaviors, including ODD and CD, as I just mentioned, are clinically a significant set of problems for a number of reasons. And in particular, they have a very considerable public health burden. So whether it's loss of productivity or the significant financial costs, for example, of juvenile justice and incarceration and family court, et cetera. Of course, significant harm to victims of disruptive behavior disorders, victims of crime, victims of violence, for example. Those are all considerable, staggering costs. Another way to contextualize or to frame the clinical significance of disruptive behavior disorders is to consider the very significant evidence on their contribution to and prediction of poor outcomes both in childhood, adolescence, and through adulthood. So poor outcomes have been documented consistently in the literature for problem domains, including alcohol and substance problems. So not just diagnosable alcohol use disorders and substance use disorders, but also an earlier onset to those problems, which actually predict worse outcomes as well. Early disruptive behavior disorders also uniquely predict, above and beyond demographic factors, for example, significant risk-taking, sensation-seeking, an earlier onset to sexual behavior and more risky sexual behaviors in particular. They predict earlier incarceration, an earlier intersection with juvenile justice and police contact, and when you follow them into adolescence and adulthood, evidence of premature death or earlier mortality as well. If we look at the evidence or the literature on early risk factors, so in other words, what are the best predictors of these emergent disruptive behavior problems, aggression, noncompliance, delinquency, and so forth, or disruptive behavior disorders more specifically, there's very consistent evidence that, for example, family adversity broadly defined. Okay, so whether that's chronic instability in the home or explicit experiences of maltreatment or neglect or physical or sexual abuse. We know youth who are exhibiting high levels of impulsivity, for example, right? Difficulties with self-regulation, for example, are at higher risk for onset of disruptive behavior problems and a more persistent pattern of disruptive behavior problems from childhood to adolescence and adulthood. Another more recent set of findings, I would say in the last 15 to 20 years, that are also very uniquely predictive of, again, a more persistent, a more treatment-resistant form or expression of disruptive behavior disorders is low empathy. So from relatively early in development, children can be characterized with respect to their degree of callousness or how empathic they are, how much guilt or remorse they show about their own negative behavior, about transgressions, and so forth. And we know from very early in development, as young as age 3 and 4, for example, that children who are characterized by low degrees of empathy or high degrees of callousness, show little remorse and so forth, show again, more likely to show a significant pattern of disruptive behavior problems as well as a more persistent trajectory of disruptive behavior problems. However, not all the evidence is negative. And another point to emphasize is that even among children who show early expressions or who are diagnosed with oppositional defiant disorder or conduct disorder, one of the outcomes actually, in fact, of youth with disruptive behavior disorders is resilience. So in other words, not all children with disruptive behavior disorders show the same exact pattern of outcome or development, meaning that there are important differences in their academic development, their social and emotional development, whether they develop other co-occurring mental health problems with depression or anxiety or substance use, for example. And so one of the things the literature has really tried to do is to identify what are some of the predictors of who fares better or who fares worse among youth with disruptive behavior disorders. And so one of the most consistently identified factors or experiences that promote resilience among youth with disruptive behavior disorders is the presence of a supportive caregiving environment, including but not limited to parent-child interaction and specific parenting behaviors. So less punitive, more positive, more specifically contingent positive behavior, parenting behavior, labeled praise, use of consistent parenting techniques, for example, are all important predictors of which youth with disruptive behavior disorders do better, relatively speaking. Another important predictor of resilience is self-regulation, which includes different aspects, but broadly defined, including things such as self-control or inhibitory control and things of this nature. So youth with improved or enhanced self-regulation who are able to physiologically and psychologically sort of cope and sort of rely on self-coping strategies in the face of distressing stimuli, for example, show better outcomes. And again, this is among youth with disruptive behavior disorders already. So supportive caregiving and parenting behavior and important aspects of enhanced self-regulation, for example, are really key facets of which youth will do better among youth with disruptive behavior disorders. So with that, I'd like to stop my presentation and pass it along to Dr. Kaminski, who will talk to us about interventions.
Thank you, Steve, and thank you to Mitch and to SCCAP for inviting me to talk today. Fair warning, this is not just another paper to me. Given the other work we've been doing here at CDC to get evidence-based treatments to more families, this is something I am passionate about. And I suspect you are too, since you're choosing to spend part of your Friday here with us. As you know, this paper updates the evidence base on psychosocial treatments for children with disruptive behaviors. So why am I passionate about that, do you ask? Well, as you guys know, families of young children with disruptive behaviors are struggling. They don't have time or energy to waste on ineffective treatment. Providers and payers don't either. If a family has a child with a disruptive behavior disorder, chances are that's not the only challenge going on in their lives. They need help, and they need something that works. That's why I'm passionate about this study. So the first question any good public health professional asks is, how common is the problem? The latest published data estimate that about 4.6% of children have a history of behavioral or conduct problems, and about 3.5% are currently reported as having behavioral or conduct problems. With today's average class sizes, that's an average of more than one child in every classroom. And of course, we know those rates will be much higher in some areas and would be even higher if undiagnosed cases are counted. On the next slide, I'll give you a little background for the study. Surely you're all familiar with the reports that Sheila Iberg and colleagues published in 1998 and 2008. This study updates that literature, covering studies published through October of 2016. Although both previous reviews covered all ages, this report narrows the scope to children ages 12 and under. We followed all the methods and procedures that were laid out in the previous reviews and the SCCAP guidelines. On the next slide, you'll see the criteria for eligible studies in this review. To be eligible, published studies had to evaluate a manualized psychosocial treatment with children with identified disruptive behavior problems, using reliable and valid measures, and have an adequate sample size and adequate analytic approach to detect effects. The ratings criteria are then applied to those eligible studies, resulting in the 5 labels on the next slide, representing the level of evidence that exists to support an intervention. These range from well-supported, for treatments with the most evidence, to treatments of questionable efficacy, for which there might be harmful effects. For those who need a refresher on the 2008 review, there was only a single well-established program in that publication, the Parent Management Training Oregon Model. 14 other reviewed programs were found to be probably efficacious. We're here today so I can share with you what's changed since then, right? Well, one of the things that's changed since then is how SCCAP approaches these reviews. Instead of reviewing packaged treatment programs, we were asked to review more generic treatment families. So today's results on the surface will look quite a bit different from the previous updates in this area. From the 64 eligible studies that we had, we identified 6 core treatment models, as shown on the next slide. The first is parent behavior therapy, which we classified as programs which teach parents how to be more effective behavioral reinforcers that involve strengthening the parent-child relationship and providing parents with more effective child behavior management strategies. As shown here, it can be delivered in groups, individually to parents with or without child participation, and via self-directed methods. The second treatment mode we saw frequently was child behavior therapy. In this, the therapist interacts directly with the child or children to teach appropriate social skills using behavioral or cognitive behavioral techniques. A classification of parent-focused therapy was for treatments that focus primarily on parents' emotions, attitudes, and boundaries, sometimes described as client-centered or emotion-focused therapies by its developers. Next, we also found child-centered play therapy. Developers of these programs describe the goal as having therapists provide non-directive positive regard, warmth, and empathy to the child. This, in theory, helps the child express their feelings and provides a safe space through which the children can explore and work through their negative emotions. Teacher training approaches typically include classroom or behavior management strategies and making the teacher a more effective reinforcer of children's behavior, much like some of the parent behavior therapy approaches. Last, we found a set of family problem-solving approaches. These approaches engage the parent, the child, and siblings, if present, in a problem-solving process that builds the family's ability to collaboratively resolve issues resulting from oppositional behavior, but doesn't necessarily specifically address the oppositional behaviors. I've color-coded these to make the results easier later on. In addition to these 6 treatment modules, we also found a set of add-on modules that were frequently tested in combination with the first 6. None of these would be considered a treatment in and of itself for disruptive behaviors, but frequently they appear in combination. We treated them separately in this review so that, for example, a parent behavior therapy program that included teacher training could be reviewed separately from a parent behavior therapy program alone. With the 64 eligible studies and the 26 different treatment families that resulted in hand, we applied the evidence-based update review criteria, and the ratings emerged. Next up, with the strongest level of evidence, there were 2 forms of parent behavior therapy: group parent behavior therapy and individual parent behavior therapy with child participation. Each of those had 8 studies that contributed to the rating. These were studies that compared the treatment to an alternate treatment or a placebo. There are, of course, many other studies of these 2 families compared to no treatment, though in the evidence-based criteria, those studies don't contribute to ratings once there are studies testing active treatments against one another. Level 2, on the next slide, shows the first 9 of 13 treatment families that met level 2 criteria for probably efficacious. There were variants of parent behavior therapy, variants of child behavior therapy, 1 parent-focused therapy, and 2 on child-centered play therapy. It's important to note here that most of these met criteria for probably efficacious based on only 1 or 2 studies. The next slide also shows the remaining 4 sets of treatment families that were labeled as probably efficacious. These 4 were higher set of components than the others. There were various combinations of parent behavior therapy, child behavior therapy, teacher training, and family problem solving. As with before, we see a small number of studies by which each of these met criteria. For level 3, we have 6 studies that were rated as possibly efficacious. 5 of those involved well-established treatment modes in combination with other components. There was also individual child behavior therapy and group child behavior therapy combination, as well as teacher training. Still considered experimental is family problem-solving training. There was only 1 eligible study which used a non-randomized design. Thus, we need to continue to watch this treatment before we make any conclusions about it. On the next slide, I'm happy to report that no studies met the criteria for treatments of questionable efficacy. I might have been a bit reluctant to give this webinar if there had been. Fortunately, that didn't happen. We did find 3 treatment families with patterns of evidence that did not align well with the evidence-based update criteria. So we've labeled those unclassifiable for now, and we detail in the paper what the patterns of evidence are. Following these, of course, we all want to know what the evidence says about for whom these treatments work best. And unfortunately, there's little we can say based on this set of studies. Most treatment families were classified based on single studies, and few studies reported outcomes separately by either age, sex, race, or ethnicity. 7 of the 8 studies that reported outcomes by gender found no significant differences for boys versus girls. And although studies came from all over the world, including North and Central America, Europe, Asia, and Africa, most studies were internally homogeneous on race and ethnicity, and so can't tell us much about the spread and the effectiveness across those domains. With respect to age, 17 of the treatment families have only been tested on either younger or older children within our age range. Now, 6 of the treatment families, including both of the well-established treatments, have been tested on the broader age range from approximately age 2 up to age 12. On the next slide, we present a little bit of information around effect sizes and follow-up. So although the evidence-based updates are not intended to be meta-analyses, you have the anonymous reviewers to thank us for pushing to include this information in the paper. The full table is in there, and we have these take-home messages for you today. The biggest finding was that there was a wide range of effect sizes, even within treatment families. With respect to follow-up, 17 of the 22 studies that reported follow-up assessments found maintained effects on at least 2 measures of disruptive behavior, and many found delayed improvement or further improvement at follow-up. So we have reason to believe that these treatments do have sustainable effects. As scientists, of course, we fully acknowledge the limitations of our methods. Study inclusion was limited to those published in English that met the evidence-based update criteria. And this approach to rating the evidence relies on vote counting, which is adding up the number of studies showing superiority, equivalence, or inferiority. While we know that vote counting does not provide the same depth of information as empirical meta-analysis, vote counting does speak to the accumulation of evidence for different treatments. We also recognize there may be some resistance to reviewing treatment families as opposed to brand name programs. So yes, treatment families are currently more difficult to find in communities than brand name programs. And yes, there is a notable degree of variability in effect sizes within treatment families. But treatment families can collectively cover more geographic area and therefore serve more families than single brand name programs. So policy and resource allocation decisions that have to be responsive to whole population needs can be greatly informed by these findings based on more generic treatment families. Also, when brand name programs don't exist in a community, referring physicians and parents can use these treatment family descriptions to identify what's most likely to be effective from what is available in their area. That means fewer families wasting precious time and energy on ineffective treatment. To recap the results, individual parent behavior therapy with child participation had previously been rated as well established, and it maintains that level of evidence in the current review. We can now also add group parent behavior therapy to the list of well-established treatments. There are 2 key differences I want to highlight between these 2 approaches. One difference lies in how many families can be served at a time. So group-based treatments are able to serve more families at once, so may provide efficiency of delivery. The other difference lies in intensity of services. Individual treatments are able to serve families more intensively, and with child participation, they may be able to serve them more effectively. Thus, there's this tension between efficiency and intensity of services that's worth noting. Overall, there was more evidence for treatments that incorporate behavioral approaches as compared to emotion-focused or other non-behavioral approaches. This finding has been consistently found in previous individual studies and meta-analyses, so is no surprise here. The findings here do align with, but are more specific than, the guidelines from the American Academy of Child and Adolescent Psychiatry, and I'm sure we'll hear more about that next. I want to leave you today with what I hope are inspirations and aspirations for the field, because I suspect most of you listening are clinicians and researchers who want to continue helping families and helping them more. These may be out of your comfort zone, or these may be the messages you've been waiting to hear. But this is what we see from our 30,000-foot view of the field. We've now got a large body of evidence about what works for children with disruptive behavior problems. We know much less about what works, how to get what works to the families who need it. So we need systematic investigations of widespread dissemination. And heretic that I am, I think we need to consider lower dose treatments that can be delivered by a wider array of providers. Doing so will not put the brand name programs or licensed providers out of business. because until the field finds effective ways to prevent disruptive behavior disorders, there will continue to be large numbers of families who need intensive treatment from licensed providers. But in areas where there are no licensed providers or there are long wait lists, a lower dose of effective treatment would be better than nothing. We also need to consider better integrating treatment into existing service systems, which can also help more families struggling with their children's disruptive behaviors. Finally, I'll leave you with a challenge. One well-established treatment family maximizes efficiency of delivery. The other emphasizes intensity of effects. What happens if we stop treating these as competitors? We're all in this work because we want to help families. So what would happen if we tried to combine the strengths of the two most effective approaches? We're just starting to see evaluation of group-based parenting programs that also include child participation, and they're promising. I'll be honest, there will be reimbursement and healthcare policy and logistical challenges to overcome with such a model. But aren't these children and families worth the work it will take to overcome those challenges? And with that, I'm happy to hand the floor over to Dr. Jess Shatkin.
Thank you, Jennifer, and it's been great listening to you both speak and to be a part of this panel. I'm very pleased to be invited, and I'm sorry you have to stare at my picture the whole time, but I don't have other slides for you. Speaking about disruptive behavior disorders from a clinical child and adolescent psychiatry perspective, the most important first thing to do is to establish a diagnosis, to identify if a diagnosis in fact exists. And we do that through clinical evaluation of the child, by speaking with the parents, by speaking with the teachers, by getting a sense of all the collateral sources in the child's life. But to understand whether a diagnosis is there or not, a diagnosis like oppositional defiant disorder, conduct disorder, or maybe some general disruptive behavior difficulties that kids often experience. And there's a huge spectrum. At the most severe end, kids are very disturbed. At the most modest end, there are fewer difficulties, but every parent struggles with the challenge of managing their child's behavior at times. So we first want to know if there's a diagnosis, and the importance of establishing a diagnosis is to tell us really about how severe and pervasive these difficulties are. If a child is facing difficulties in every domain, home, school, after-school activities, we take it much more seriously than if a child is only having difficulties at home, because that's where it always starts, and we expect some degree of difficulty at home. So we're looking to see again how severe it is first. We're also looking to see if there are any comorbid conditions or co-occurring problems that the child's facing. These may include attention deficit hyperactivity disorder, learning disorders, anxiety disorders, depression, autism spectrum disorders, and others, drug use. But these kinds of things will certainly bring to the surface disruptive behaviors more readily, and they will often be other sources of concern that we can treat. And when we treat these areas, if we treat ADHD, for example, or learning difficulties or anxiety, we often see disruptive behavior improve. So identifying whatever else is going on and addressing that with evidence-based treatment is important. If we're left at the end of that search for a diagnosis and an understanding of the child, and we've gone through the comorbid or co-occurring conditions, at that point, if we're left with considerable oppositional and defiant or conduct disordered behavior, then the first line of treatment, as Jennifer Kaminski just told us, should be behavioral parent training and psychoeducation, essentially. Educating the parents, educating the teachers, educating the child to some degree, and working with the parents on behavioral approaches. These approaches are time-worn. They've been around since the days of the caveman. They're the kinds of things that solid, well-structured and organized and thoughtful parents do automatically, but we can teach them in a very direct and applicable way so that parents can call on these techniques time and again, and they will definitely see improvement in their children's behavior. Whether we use parent management training, parent-child interaction therapy, or another one of the modalities that have been proven to be evidence-based, the general parent training approach is valuable and helps us a great deal, teaching parents about how to use positive reinforcement, how to give effective commands, how to selectively ignore, how to use scheduling, how to use rewards, and then finally limits and consequences for bad behavior. The emphasis here generally is on the positives, 4 or 5 to 1 positive to any kind of limit setting or negative. You really want to emphasize effective commands and positive reinforcement. These work better than anything else. And this is the clinical approach we take. And in my clinical work, whether it's in groups or individual, this is where we always start with parent training. We aren't excited in general about using medication for the treatment of oppositional defiant disorder or conduct disorder, largely because we've not yet been able to prove consistently that these medications are specific to the difficulties that kids have with these disorders. No medication is approved by the Food and Drug Administration solely for the purpose of treating conduct disorder or oppositional defiant disorder or generally disruptive behavior disorders. And although medicines can be helpful, they are more of a shotgun approach. We're going to calm some of these behaviors. Often when we use medicines, we're going to decrease some aggression and agitation, but we may not absolutely treat the symptoms of ODD and conduct disorder, oppositional defiant disorder and conduct disorder. And again, there's a mix of where these disorders come from. There is undoubtedly some biological predisposition for kids to be more disruptive or more calm kids or of one temperament or another. But there's also a lot in the family, in the home, in the school environment that contributes to this. So again, our treatments with medication are somewhat generic and they're more shotgun approach. If we must use medication after we've treated comorbid conditions, if they exist, after we've applied behavioral parent training or consistent along with that, we will typically try and start at the milder end. And the milder end would be antihypertensive medications, or what we call in psychiatry alpha-2 agonists. These are medicines that were designed for blood pressure treatment in adults. And over the years, we've found that a few of these medicines, which go by the name of clonidine, or guanfacine, and I'll give you the other names for these as well, have a modest amount of evidence. We can see them helping kids to calm down, helping them to settle down, helping them to feel less aggressive, to engage in less agitated, aggressive behavior, to take a breath or so before they respond. Now, these medicines have been around for 40 years. We've been using them for children for a long time. Kids with disruptive behavior, again, they're typically, not always, but typically the first line because they tend to be well tolerated. They do sometimes make some kids a little bit sleepy, but they are often helpful. The most evidence that we have rests with a medicine called clonidine. The trade name is Catapres, and there's a long-acting version called Capve. And this medicine is given anywhere from 2 to 4 times a day, and it will, again, help to decrease agitated behavior. Some parents may, the practitioner may recommend to use this medicine for the treatment of ADHD because it does help with impulsive and hyperactive behavior. It also helps, clonidine in particular, with sleep, with kids who are having difficulty settling down at night to sleep. It's non-addictive. It rarely has significant side effects other than sedation or sleepiness. The other medicine, guanfacine, trade name is Tenex or Intuniv, which is a longer-acting form. There's considerably less study in this drug. It's mostly around chart reviews, essentially the kinds of patient experiences that doctors and patients talk about. So we don't have good double-blind placebo-controlled trials for the use of these medicines in, or minimal amount of that data for the use of these medicines with disruptive behavior disorders. But in the treatment of ADHD, again, for the impulsivity and hyperactivity, these medicines are approved by the Food and Drug Administration as, again, augmenting or supportive treatments for ADHD. When an alpha-2 agonist, a clonidine or guanfacine, is not effective, we then go and review the diagnosis again. Are we missing anything? Is there anything else we should be holding on to or thinking about in the life of this child? We shouldn't just throw another medicine at it. We should be thinking thoughtfully, are the parents actually engaging in parent training? Is the child's comorbid or co-occurring conditions being treated? Is the teacher on board? Is the after-school program on board in helping us to think through this child's behavior throughout the day? If all of that has been done, and if the alpha-2 agonists are not effective, then the next medication we will choose, most typically, not always, but most typically, will be an antipsychotic or a neuroleptic medication. Now, these medicines sound scary, I know, to a lot of people, and in some cases it is a little bit like hitting a fly with a hammer. These are very strong medications. They were designed for the treatment of schizophrenia and psychosis. They've since been studied in bipolar disorder, dementia, anxiety, depression, and they do have utility in lots of those areas. But the most common reason we use them for children has to do with disruptive behavior. So I think in many cases, my editorial is that these medicines are reached for more quickly than they ought to be in some cases. Still, having said that, when they are used, they are often, not always, effective. And the best data lies with a medication called risperidone or Risperdal. That is a medicine that's been studied. It's one of the newer antipsychotics, newer meaning it's only about 25 years old, and it has a different side effect profile from the older antipsychotics that caused a lot of movement disorders. Risperdal commonly causes weight gain, not always, and some sedation, not always, and some tremor, not always. But the other side effects that we used to see with the older antipsychotics, people being stiff and people drooling and not being able to move well and having chronic twitches and tics, those side effects are much less frequent with Risperdal. So again, it's a medicine that works effectively. We do have some data on it. We have a lot of clinical experience. Other medicines in this class include Abilify and Seroquel and Geodon and Latuda and Zyprexa. These medicines all work. They are all effective to some degree. Again, individual experiences may vary, but the data that we're going on, we don't have these beautiful randomized controlled trials for the use of most of these medications in children with disruptive behavior disorders. So we use them when we must, but we're not typically excited to use them unless we really have a child who is acting out severely, putting himself and or others in danger. These are the kids who are, tearing up the classroom, who are going after the teacher, who are going after their parents, who are going after their sibling, who we just can't find another way to help them settle down. And again, these medicines are often effective. They are off-label for the treatment of disruptive behavior disorder, again, which means that the Food and Drug Administration has not approved them specifically for this purpose. The closest we've gotten is the approval of Risperdal and Abilify, two of these medications, for the treatment of irritability in autism spectrum disorders. So for kids who suffer with autism and have a lot of irritable, agitated behavior, these medicines are sometimes used to settle that down. Again, these medicines show their greatest utility when the disruptive behavior disorder is comorbid or co-occurring with something like autism spectrum or intellectual disability. But in the absence of that, they can often be helpful, sometimes for their sedative effect alone, but our goal, of course, is never to sedate kids for no reason. Our goal is to help them to be themselves and yet manage their disruptive behavior with a little more thoughtfulness. Now, these medications, the alpha-2 agonists, the clonidine and guanfacine, those antihypertensives, those are pretty easy to apply with modest monitoring. You need to check the heart, listen to the heart and the rhythm of the heart, and check the blood pressure regularly, but that's really about it. Whereas with the antipsychotic medications, we need more extensive monitoring. We need to check blood levels periodically around the time that you start and shortly thereafter. We sometimes will want to get an EKG. We certainly want to listen to the heart and get the blood pressure. And we need to see the kids more frequently if they're taking these medicines because we need to do more active monitoring. Finally, if those are ineffective, or some people may, as another line of treatment, instead of using the antipsychotic medications first, they may choose to use mood stabilizers. These are medicines that were designed for the treatment of bipolar disorder, really for the mania in bipolar disorder, which is often psychotic in adults. And the drugs here that have been most commonly explored are lithium, Depakote or valproic acid, and Tegretol or carbamazepine. And these medicines can be effective. The data is much more scant. The best data amongst the mood stabilizers lies with lithium. Lithium's primary job is as an anti-manic agent, but it has moderate antidepressive features as well. And again, it is a standby and a very useful treatment for bipolar disorder. All the studies that have been done with lithium in the treatment of disruptive behavior have been short-term, inpatient studies. So again, it's these medicines in the antipsychotic and in the mood stabilizing class are all again, you're off-label. The FDA hasn't felt that the data is strong enough to wholeheartedly recommend these medicines for the treatment of disruptive behavior disorders, yet we have families and kids who are suffering so much we will sometimes use these medicines. These two classes, the mood stabilizers and the antipsychotics, require a good amount of monitoring. Again, with lithium, for example, you need to be thoughtful about your diet, about other medications you're taking. Now, having said all of that, these medicines can be very effective, and we will use them when we need to for the treatment of disruptive behavior disorders. All right, so to summarize, First, establish a diagnosis. Figure out if there's a diagnosis that is treatable, that is something that can be addressed directly. Secondly, if you do find a diagnosis, whether it's disruptive behavior like oppositional defiant disorder or conduct disorder, look for something else. Look for a co-occurring condition. Commonly in kids with ODD, oppositional defiant disorder, and conduct disorder, we'll see things like ADHD, learning disorders, anxiety disorders, mood disorders, depression, autism spectrum disorders, and for those we have treatments as well, both therapies and medication treatments that are validated and useful, well, with the exception of learning disorders. But the others, we have medications and behavioral treatments that are very effective, and we should start with those. If we continue to see behavioral difficulties, we start behavioral treatment, which is typically parent management training of some form or other. And if we must use medications, our typical modest first line is alpha-2 agonists, clonidine or guanfacine, then either antipsychotic medications or mood stabilizers, which can be effective, but again, they're quite strong and often have more side effects and require considerably more monitoring. And on that note, I'm done. I'm going to hand it back over to Mitch. Thank you for giving me the time to speak with you.
Thank you. Before turning it over to the Q&A section of our webinar, I'd like to thank the presenters for reviewing the state of the science and the evidence for a variety of different treatment approaches for disruptive behavior disorders. As a reminder, if you would like to ask a question, please submit your text through the Q&A section of your attendee control panel on your screen. We have a few questions in the queue, and the first one is for Steve. Some people believe that the use of an evidence-based psychosocial approach requires the use of a manual. Can you comment on whether these are meant to be manualized treatments?
Thanks for that question, Mitch. That is, I agree, absolutely agree that there's often that assumption that specific treatment protocols, sometimes people would call them like name brand protocols, must be adhered to in the treatment of disruptive behavior disorders. But I think that's sort of an overstatement. I think what's more relevant is sort of evidence-based decision-making insofar as thinking about clinically what are the common or key kind of ingredients of these effective protocols. So among classes or families, to use Dr. Kaminski's term, of effective or efficacious treatments, what are the kind of key ingredients that are common among these effective protocols? I think that probably from a kind of a bottom-up perspective is what clinicians should sort of most be attending to, rather than sort of necessarily thinking that they have to adhere to a specific sort of clinical protocol for disruptive behavior disorders. One way to become more informed about evidence-based protocols in general for not only disruptive behavior disorders, but for other dimensions of child psychopathology, including some of the key elements, would be to visit the website, effectivechildtherapy.org, which is an excellent resource that provides really sort of up-to-date current state of the knowledge around evidence-based practices for a very sort of wide array of common referrals for child mental health concerns.
Okay, thanks. Our next question is for Jennifer. We've heard about the state of the scientific evidence for a wide variety of approaches. Given the results of your work in the review, would it be considered unethical to offer treatment that is not well established based on research?
Certainly that ethics question is one for an official ethics panel, so I'll answer carefully here. Fortunately, none of the studies that we reviewed reached the level of what's called questionable efficacy, right, where there are known harmful effects. So if I were in the position of referring families or friends to particular treatments, if there were treatments known to have harmful effects, certainly I would consider that unethical. If the highest level of evidence treatments are available, certainly those would be preferable. But if you're out in rural areas, if you're in areas where you simply can't find those highest level of evidence treatments, if you're stuck with a long wait list and your child is absolutely struggling and you are struggling, then trying one of the therapies with somewhat lesser evidence but no harmful evidence. There's no reason to believe those are going to hurt. They can only help the parents along in trying to manage those difficult behaviors.
Thank you. Jess, the next question is for you. You've talked about common comorbidities and the need to treat these before treating disruptive behavior disorders. Are there case presentations that warrant treatment of ODD or CD first?
That's an interesting question. Sure. I mean, typically what we want to do is treat what is the most severe issue. The reality is, though, and so we'll often treat two things at the same time. But if I have a child come to me who's moderately anxious, maybe not severely anxious, and is having a lot of oppositional and defiant behavior, I'm really going to want to get hold of that anxiety. I will go ahead and offer the parents parent training, and I will work with them around the school and the other things that we may need to address in the child's community and life. But I really want to help to get control of that anxiety. Of course, I want to figure out where it's coming from, and I want to decide whether a therapy or education or a medication intervention is the right or some combination. But once we get hold of that anxiety, we see the child settle down very commonly and the disruptive behavior not be so intense. So again, there are kids who are, going to have a lot of severely disruptive behavior, and it may be more severe than the comorbid condition, but I wouldn't ever ignore the comorbid condition. I would jump in while treating the oppositional defiance of the conduct, but I'm always going to also treat the co-occurring problem as well.
Steve, you made reference to the importance of trauma history. Do you view trauma screening and treatment as part of the protocol for treating disruptive behavior disorders?
It's a really good question. We know that children both at risk for disruptive behavior disorders as well as youth themselves who have actually already been diagnosed with disruptive behavior disorders have both a frequent history of exposure to trauma or, again, for those at risk, have experienced traumatic events. So as far as screening, absolutely. I think one of the challenges with disruptive behavior disorders, but really kind of child mental health more generally, is to sort of try to get some traction on kind of what the disruptive behavior problems are caused by or might be secondary to. So if there is a case formulation where the disruptive behavior disorders or symptoms, let's say, emerge secondary to maltreatment or trauma or some other kind of adverse experience, then I would think that trauma may be at least a strong candidate for being one of the principal sort of causal influences on the disruptive behavior problems, in which case then that thinking about evidence-based protocols for like trauma-focused CBT, for example, may be sort of in a triage kind of sense more prioritized relative to, let's say, some of the parent management kinds of things that were just discussed before. So I think at a minimum, trauma screening and evaluation should sort of go part and parcel with evidence of sort of significant disruptive behavior problems, and then develop, depending on screening and a developmental history in terms of onset, primary, secondary considerations, and so forth, it may become an equally important sort of part of intervention, and perhaps, if not the primary intervention first.
Jennifer, your work focused on children 12 years and younger. Can you comment on why? And also, do you have any recommendations for the best source of a review of effective interventions or treatment families for disruptive behavior disorders in youth over the age of 12?
The first part of that one, actually, it's a nice, easy question. Thank you for that one. We were asked to focus on 12 and under is the simple answer. Now, the more complicated answer is because there's very good reason to believe that the approaches that might work best for younger children would not be the same as the approaches that would work best for older children and adolescents. We know from lots of research and confirmed here that parent behavioral approaches are effective here with ODD and CD. We also know from other research parent behavior therapy works well with young children with ADHD and with lots of other conditions. We've seen lots of studies that once you get into older children and adolescents, more child-focused therapies tend to appear and can be more effective there. So yes, SCCAP and the journal have recently published the review that includes the 13 and up crowd. Michael McCart is the first author there, and I'm certain that it is on the Effective Child Therapy website, and folks can go there and find the results.
Jess, the National Institute of Mental Health has gradually moved towards a more biological and dimensional conceptualization of psychopathology. Based on our discussion today, what do you feel may be the most important funding priorities?
Funding priorities. So this is an interesting point to bring this up because, again, for many years we were able to achieve funding for studying clinical disorders with clinical treatments. And as you say, that has gone a little bit to the wayside. The efforts are more in biological science. And while I think that it is very important for us to understand the biological underpinnings of these disorders, they certainly don't exist in a vacuum. And we are often stuck with not knowing which treatments are the most effective, which is a real tragedy. And often when I pick up a family in the waiting room or in the clinic or the emergency room or in the inpatient unit where I'm working, and I get this, I know what's going on, I complete my diagnosis, I often don't know what the most effective treatment to give them is. Now there's a lot of bias in clinical studies too, but I'm not sure that we're at the point where we're going to be able to take, by and large, we're not at the point where we're able to take the developmental psychopathology research and turn that into a clinical practice. We've got to start somewhere, however. I'd like to see a little more clinical intervention studies funded personally, but that's the opinion of one. I do want to say, if I may, on the last question you asked, Jennifer Kaminski, the idea of why 12 and under, and generally from a clinician's point of view, parent training and behavioral parenting approaches work very well with kids when they're smaller and they're younger, which is why we encourage parents to get on top of it from day one. Because the older kids get, the bigger they get, the more independent they get. And by 13 or 14, they can walk out the door and say, screw you, I'm gone. So what you really want to do is get hold of that behavior as soon as possible. If you're a parent listening and your child's 15 or 16 and you haven't gotten hold of that behavior, all hope is not lost. These techniques are still effective. They're less effective. And so we really need to start as early as possible.
Thanks. Steve, is there a recommended best practice assessment protocol to reliably diagnose disruptive behavior disorders that would help to control for over or underdiagnosis and subsequently could be used to assess post-intervention outcomes?
Sure, great question. So as a general class with respect to diagnostic ascertainment of disruptive behavior disorders, things such as structured diagnostic interviews, of course, and sort of rating scales, normed rating scales, usually provide the most evidence of reliability and validity and so forth. So those can include sort of freely available rating scales. So for both ADHD, ODD, and conduct disorder, the Swanson, Nolan, and Pelham SNAP rating scale, or the disruptive behavior disorder rating scale, which are freely available, are again psychometrically sound and I think sort of best practices with respect to assessment. The sort of a second aspect of the question around overdiagnosis or underdiagnosis, that's a little bit more tricky, but I think it comes down to sort of kind of clinical judgment and sort of decision making around what are some alternative explanations for the disruptive behavior problems. And going back to what I was saying before, is that one of the challenges is that the heterogeneity we see in disruptive behavior disorders. So you may have different kinds of behaviors caused for different reasons. So clinically, I think to sort of try to combat over or underdiagnosis is to really attend to some competing explanations, whether it's comorbid explanations or some other idiopathic influences that might better account for the clinical presentation of disruptive behavior disorders. The measures or the rating scales that I measured before are perfectly well validated for use as treatment outcome measures as well. I would also just add that in addition to symptoms, because those rating scales and structured interviews typically attend to the symptoms of disruptive behavior disorders, that it would also be important to emphasize functional impairment. So peer relationships, academically, family relationships, and so forth, since those are separable from symptoms and oftentimes are of greater importance and priority to families as much, if not more, than the symptoms themselves.
I think we have time for one more question. Jennifer, with regard to parent management training with child involvement as a well-established treatment, was there any indication of which aspect of the child involvement, above and beyond the parent management training skills themselves, are contributing to the best outcomes?
We certainly can't tell from these studies. The degree of specificity which would be classified that was merely whether or not the child participated in some way in the therapy with the parents. So was not We did not go as detailed as what exactly the child would be doing or even how many sessions. So even having the child in one of the sessions would have been enough to put them in that category. There's certainly other research that we can point to that looks at parents actually practicing the skills that they're learning with the child in treatment is a fairly strong predictor of outcomes among these types of programs. So it's not simply that the child is also receiving treatment, right? That would be a parent behavior therapy plus child behavior therapy model. The individual parent therapy with child participation really is the child participating with the parent in treatment, presumably practicing the skills that are being learned.
Thanks. I'd like to thank Drs. Lee, Kaminski, and Shatkin for their participation today. If the listeners have found this evidence-based update useful, please be sure to visit jccap.net to access other papers within the evidence-based update collection from the Journal of Clinical Child and Adolescent Psychology on other disorders. And if you would like for parents to know about these reviews, please direct them to effectivechildtherapy.org. On behalf of the Society for Clinical Child and Adolescent Psychology, thank you all for your time today. Have a good weekend.